Thank you, Arip sir, for this wonderful uh, opening statement to the instruction course. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. There are many contemporary tools in the market right now operating with us, but my job is to take you through some of those contemporary tools which are essentially essential for the Toric IL calculation. So I'll just run through three of the equipments that are important as far as the Toric IL planning and implantation is concerned. Image guidance and biometry, we have both of them combined together now. Topography, anterior segment OCT, and biometry, again, all three combined into one equipment. And then finally, we'll just look at the aberrometry results and what do they teach us with regards to toric IL planning. So the machine that combines image guided and biometry is called the Argos. And this is the way it works. It takes the measurement in less than a second. And these are all the measurements that it gives us in a flash, all the measurements that it gives us in a flash. This is how this screen looks like. It's still just like Varian, it's older gen equipment. It uses a single light of 16 LEDs at 2.8 millimeters the central cornea, but it gives us a very dynamic keratometry values. This is something that is important in this machine. This central green should be aligned with a cross. That's when you should click the joystick to start taking the measurement. That's one. And second is this green line out here. As you can see, it lies parallel to the corneal vertex. If it does not lie parallel to the corneal vertex, then you know that the eye has not been properly aligned to the machine. Then you have to retake the whole reading. It has two USPs, this machine has two USPs. One is it takes into account the differential refractive indices of the tissues through which the light ray has to pass. The earlier equipments, what they used to do was they used to take 1.3375 as one refractive index, common refractive index for all the tissues in the eye. This takes differential refractive indices. So the axial length changes, however minimal it may be, but it does become clinically significant in some of the issues. The other thing is extended retinal view, or ERV. Let's understand what that is. First, this is the refractive indices of the different tissues that the light passes through, and the machine takes into account all of that. And second is this ERV. So what it does is in the dense cataracts, in the normal mode, it calculates the length from the corneal vortex to the posterior capsule. And then you switch on the ERV mode, which takes the distance from the posterior capsule to the cornea. It just enhances the view modifies the view that is taken from the posterior capsule to the cornea. Then it stitches them together to give us the complete axial length. And we can analyze it to see whether they are aligning properly in one line or not. If they're not aligned properly, we can retake the reading. But what has given me at least is the liberty to subject the most densest and the whitest of cataracts even to the proper axiometric values. It's really, really perfect, this machine, when it comes to axiometry in those circumstances. The other thing it does is it plans the cases for you. As for example, in this case, as you can see, it predicts a T3 and a T2 in the same patient to bring about the same result, but the incision size is different. With a T3, you can achieve the same result with a 2.2 millimeter incision as you can achieve with a T2 producing a 2.8 millimeter corneal incision. So it essentially flattens the axis a little more. So if you do not have access to that particular variant of toric in your inventory, you can modify that with the help of this machine. This is another patient who had planned, whom we had planned for a trifocal implant, but if the patient was being left with a 0.58 cylinder post-operatively, the machine told us that. We asked the machine to do an arcuate planning since this patient was also opting for femto, and the machine did that. So it told us that there is an arcuate incision, paired arcuate incision to be done at 152 and 332. The arc length should be 22 degrees, the depth should be 85%, and the diameter should be at 9 millimeters of cornea. Then the residual refraction would be 0 or negligible, is what the machine told us. So these are the advantages of the image-guided system. This is another patient wherein there was an expand series IOL required of +3 diopters, but since the patient was also opting for a femto platform, we managed to neutralize. After T9 implant, also the patient was left with some amount of cylinder, which we could adjust with a paired arcuate incision on the femto platform. So this is what the Argos does in a nutshell. Of course, this can be expanded to a lot more. Anterion is a machine that comes from Heidelberg, and it combines ASOCT, wavefront, and axiometry, along with a few other things like the topography as well. This is how the picture looks, and this is how the printout comes. You can also have a reliability index looking at the A-scan picture that it gives you, a complete A-scan picture that it gives you. It does give you the chord mu length as well, which we commonly call as angle kappa. And this is a topography, the anterior and the posterior elevations. However, unfortunately, it only expands the 8 millimeter zone of the cornea. It doesn't go beyond that, so you don't know what's happening in the very peripheral parts. This is the acquisition quality. The machine gives you a printout of, a window of acquisition quality. So it does give you a fair bit of idea regarding the ocular surface, the tear film and lid, whether they pass or not. So the machine senses that there's something wrong with the ocular surface. You can go back and treat the patient for a few days with lubricants and then call him back for another set of biometry just to achieve perfection. It gives you an idea regarding the lens tilt, so that's also important in toric. Some of the patients wear glasses, but actually the corneal indices do not show that they have toricity on the cornea. That might be a lenticular astigmatism. When you subject them to the ASOCT, you can see that the axis of the eye does not match the axis of the lens. It's slightly tilted, so that's another information that you can get. It does give you the access to calculate the toric IL power based on predicted posterior corneal astigmatism and measured posterior corneal astigmatism, since this is a tomographer. So this is one example where the predicted corneal astigmatism with the predicted posterior corneal astigmatism, the IOL power, the T3, the toric version came out to be T3, but when we switched and we went to the measured posterior corneal astigmatism, it gave us a T4 reading, as you can see down below. However, if there is a disagreement between the predicted and the measured posterior corneal astigmatism values, I still go with the predicted value because the Barrett's algorithm is too good predicting the PCA for every individual case, as we have found out over the time. This is the wavefront of the aberrometry that I use, the eye trace. Now this patient, for example, wanted a trifocal. As you can see, the angle alpha is doing fine. We can go ahead and plan a trifocal. The delta or the toricity index in the cornea is 0.95, so fine. We can go ahead and put in a trifocal toric. But what's interesting is on the corneal front, if you look at the total spherical aberration, that is somewhere around 0.009. So you have to be very careful in choosing the IOL which has more negative asphericity, because the total resultant asphericity of the eye should be slightly on the positive side or should be at 0. It should not go on to the negative side. So what happens when the total spherical aberration goes on to the negative side is, this is one patient wherein you can see the spherical aberration of the total eye is minus 0.001 mu. This is a post-operative reading of a patient. The patient came to me very dissatisfied with the quality of vision he had, and when I subjected him to the eye trace and then the dysfunctional lens index, look at the distortion the patient is having from the internal plane. Nothing wrong, everything superb, very well done surgery, but still the patient is not having a very crisp vision because the total resultant negative spherical aberration was on the negative side. And finally, before I sign off, this is also something that we must look at, the ocular surface. If we have access to the ocular surface analyzer, dry eye suite, then wonderful. If not, then we can do certain simple tests to rule out whether the ocular surface is doing well or not. This is one such patient who also had qualified otherwise for a trifocal implant. But when we saw the patient preoperatively, the lipid layer was doing very bad in both eyes, standing at 57 and 55. So sent the patient back with antibiotics and ointments and warm compress for a period of 3 weeks. And the patient came back, the lipid layer improves to 87. Now you're much likely to get a proper biometry reading, which will help you identify the exact toric placement, because this is what happens when the dry eye comes in. If you look at the right eye picture of this particular patient, this one of the Myers is not properly taken and it's marked cross. The delta in that reading shows to be around 0.27. The delta in the other two readings where the Myers were proper shows to be 1.56 and 1.30. So the total delta comes down a lot, which is 1.09 as the reading shows here. This patient does not require 1.09 of toricity to be corrected. He requires more toricity to be corrected. It was modified because the eye was dry when this first reading was taken. So if you come across these sort of readings, it's important for us to actually go and analyze the readings that come from the biometry rather than blindly believing them and finding out whether the surface is doing well and the biometry has been taken in the proper settings. So these were just a few nuggets on the toric calculation with regards to the contemporary tools that we have in the industry. Thank you so much for the opportunity and the kind attention.